Good evening, everyone, and welcome to this Facebook Q&A around the Surgeons at the Edge of Life Series 4. I'd like to thank everyone for joining us, both members of the public, CUH and Papworth staff, and then obviously the stars of our series, and also Daniel Barry, our behind-the-scenes star of the series as well. So first of all, I'm just going to get everyone to introduce themselves, so I'll just go around the room effectively and volunteer each of them in turn and get them just to let you know who they are, although hopefully you'll know already from the series, and just tell you a tiny bit about themselves. So I'm going to start with you, Noreen.
Hi, Noreen Wardani. I'm a consultant cardiac surgeon. I've been working at Royal Papworth Hospital for the past 10 years. It's a fantastic place to be, and I also do some lecturing at the University of Cambridge. So thank you for those of you who watched the programme, and welcome any questions.
Thank you. Terry Louise.
Hi, I'm Terry Louise. I was the clinical perfusionist on the day for Noreen's episode. Bit of an unusual job that you probably not really heard of before. I've worked at Papworth for 6 years now.
Lovely, thank you. Ian.
My name's Ian Grant. I'm a consultant plastic surgeon, and hand surgeons can be from either plastic surgery or orthopedic surgery backgrounds. My expertise is in children's hands, reconstruction and microsurgery.
Mimi?
Hello everyone, my name is Akemi Irene and I'm head and neck surgeon at Adam Brooks. Most of my work is cancer work and airway, and it's lovely to be here this evening.
Thank you. And Aman?
Hi, well, I'm Armin Kuna and I work at Royal Papworth Hospital with Noreen, and sometimes if I'm very lucky I work with Mimi as well, and I also work with plastic surgeons, but I haven't been fortunate enough to work with Ian Grant yet. So that's what I do.
Okay. And then finally I'd like to come to Daniel, the series editor.
Hello everyone, I am the series editor of Surgeons, and that means I'm in charge of the day-to-day running of the production, and I have actually been involved in one way or another with every single series since the first one. So it's very good to, yes, still be here.
Well, welcome, Daniel. It's really good to have you on this call because it will give us an insight onto the other side of the camera as well, and what it takes to run a series like this. So a couple of housekeeping things. There is an opportunity for our viewers to ask questions, and there are two ways you can do this. You can either insert them into the Q&A box, and then they'll get passed on to me and I will ask. And the other place is the Facebook page. So if you insert the questions into the Facebook comment box, they will again be picked up and passed on to me and I'll ask them on your behalf, okay? So I've got a few pre-prepared questions just to get us warmed up, and then I will start moving around and picking up questions from the members that are watching this as well. Okay, so it's quite challenging, these sort of surgeries. So I'm going to start with Noreen. How do you remain so calm and composed when there's effectively you're changing that valve, blood could be going everywhere? It's challenging, isn't it?
Yes, I think years of training has sort of taught us to deal with patients in these situations, and I think it's always remembering the importance of what you're doing there, the importance of the patient at the center of the operation, that everything you do is focused on that patient. And I think once surgery starts, you become lost in the middle of the operation. I think it's the concept of flow, like Roger Federer, or concert pianist. In the middle of an operation, you are just so focused on what you need to do. And I think it's also to remember that you've got an amazing team, amazing set of professionals around you, all focused on the same job. So although they're relying on you for guidance and direction, I think it's understanding everyone in that team brings together different components to make the outcome great. And so I think it allows one to remain calm and composed, knowing that you're surrounded by a lot of great people. But yeah, I think it's an important aspect of the job, and so thank you for asking that question.
And I think you've led very nicely into a question for Terry as part of that team that keeps you calm and composed. And this is actually from the people watching. You do an amazing job. So how did you get into that? And what are the opportunities that you've experienced because of it?
I think, yeah, like Lorraine sort of said, years of training and things like that. It is a cool job, and it never wears off. But yeah, I very much fell into perfusion. So I did a biomedical science degree first, and then I got into it through a friend of a friend. Just I'd never heard of it before. And yeah, opportunities wise, being at Papworth's great because you've got the opportunity to see pretty much everything other than pediatrics. I think we do quite a lot of specialist stuff here, so I think, yeah, the experience of working at a big hospital like Papworth is really great.
Fabulous. So obviously this is slightly different being filmed whilst you're performing the surgery. And I know, Aman, you've done it before. So was it any different this time around?
Case was different. The team was great. Daniel and his colleagues are fantastic. And my operation was much shorter. The last one took about a day and a half. So
yes,
it's only a third of the time.
Yes. So I'm going to come to Ian actually with that question as well, because you did a trauma case. So this is much less planned than the other team cases. So how did you find it?
How did I find the experience of being filmed? Theatre 20, which we were filmed in, is my usual theatre. So the environment hadn't changed. The camera staff were pretty sympathetic. I've been filmed a few times for demonstrating surgery for courses and things where the camera crew were quite intrusive, but the Daniels people were really good at stepping back and being almost invisible. Emily, the producer, is that the correct title? It was also pretty straight and very much that the patient's care and the expediency of the patient's care and the balanced decision making on the patient's care was the first priority. So I felt trusting, and I didn't feel that they were intruding. So I felt pretty comfortable with it. It wasn't a problem. I felt a little nervous for some of the other members of staff, but again, I think the camera crew made it easy for them.
Okay. So Mimi, one of the questions that's come up is, how do you stay awake for so long? Because you do some of the longer operations as well. So how do you focus for all that time? And then what do you do to wind down when you get home at the end of the day?
Thanks for the question. I work with a big team, and I'm not doing every single thing from start to finish. In fact, in the first episode, there's a huge part of the operation that you don't get to see, which is the temporal bone resection. And so you're in and out of theatre. And when you're in there, just as my colleague Naren just said, it's that focus and flow. And when you're doing something you enjoy, time passes very quickly. And that's what accounts for most of the time, doing the bits that you enjoy, teaching, training, and also interacting with everybody else around you. We're not operating in silence. I mean, we usually have a little bit of music in the background. We're usually chatting about other things, even though we're concentrating on the patient as well. So we're giving our full attention to the patient, but like any other workplace, there are real life interactions with people that make it a lot more enriching environment. So it's and so that time passes quickly. And of course, you take breaks. You make sure you get some lunch. You're talking to your colleagues. You keep hydrated. And regarding winding down, I'm quite a chatterbox. So I'm always chatting to my colleagues, and if I take a break, I'm out and I'm talking, and I actually relax that way. So I tend not to take a lot of baggage home with me, because I'm debriefing and I'm decompressing before I leave work. And then when I get home, I'm a foodie. So as long as I'm enjoying time with my family, and I get to have a good meal and relax, and watch something exciting, mindless on television or something. Yeah, so that's what I do during the working week. And of course, at the weekends, I'm doing other social things, and a little bit of working out, and enjoy my personal time. So I try to balance that quality of life. I need to come back to work the next week feeling refreshed. Yeah.
Yeah. So, Aman, you've mentioned previously about being relaxed and wellness stuff. Is there anything you'd like to add to what Mimi was just saying about how you wind down or get your resilience back at the end of the day?
All the things that Mimi does, but just in the context of my own family and my own life. I came off my push bike a few weeks ago and injured my hand. And at that point, I had the choice of either putting my hand into splintage or keeping it moving. And as a surgeon, stiffness of the hand is a real problem. So I kept it moving, but I couldn't ride my bike. So I started walking and slow jogging to and from home. And I think exercise is really important. So as a result of that, most days I do about 11K walk, or I'd like to call it running, but when my jog actually came in slower than the walk, I realized that walking was a bit faster. And I really enjoy that, because the Cambridge environment is, if you walk or cycle, you have a different experience to the roads. And so I go along a little brook and walk through fields, avoiding cows, not at this time of year, but other times of year. And so it's really nice.
Yeah. So that's sort of actually those two things, hurting your hand and thinking about mental resilience, makes me think about when cases don't go quite as expected or not to plan. So Ian, you had that quite challenging trauma case with the devascularized hand. How do you sort of process and go through?
With the major trauma patients.
Sorry, carry on.
I think you're asking, I missed that there. I think you're asking, how do you deal with...
If things aren't going quite the way you'd like them to go, if there's a change in the plan, that was quite, you came into that case not necessarily knowing, because it's a trauma case, and then seeing how it developed and the interaction with the patient and things like that.
So I will have seen the patient before surgery, and I will have made it pretty clear that there are several different outcomes. I'll keep it pretty simple, but there's no shortfall in the preparation of the patient for which way it could go. Also, it's not that we are attempting something that fails and falls. Generally, if we're doing a reconstruction, say for example, microvascular tissue transfer, it's a pretty reliable surgery. 97% of them work. But to get there is an algorithm. There are different paths that could be followed. And just because we're not following the optimal path, it doesn't mean that there's a sense of disappointment. We're doing the very, very best we can for these patients and for these individuals, and we are helping them in the aftermath of a really devastating event. And the energy that would have gone through Adrian's hand is huge.
Yeah.
70, 80 miles an hour hitting the partition. So to get him alive and get him to theatre, to get him to a point where there are options to reconstruct is quite a challenge. And you feel bad when you've shortchanged somebody, and I don't think we do. So although there is a sense of loss, it's contextualized by doing everything you can. Does that answer your question?
Yeah. It's part of the package of how we deal with these tricky cases, which makes me think, Mimi, of your case, the very sad case of the gentleman who had the very rapidly enlarging tumour. Would you like to just talk about that a little bit, and how you manage those sort of patients, how you manage yourself and your team in those situations?
Yes. Well, first of all, it was a privilege to meet him and to have been involved in his care. We work as part of a multidisciplinary team. And so whatever decision we're making, you have that burden being shared with other people. In Chris's case, it was complex because of how advanced the disease was. And at that point, you start to think, is it worth it? That's the most important thing. And you think about the fact that as a clinician, you're also custodian of healthcare resources as well. So the theater time, or all the work that goes into this. And you're thinking you've got a number of patients that you also have to look after. But of course, there's a human being sitting in front of you, and this is where the decision making comes in. And some of that comes with discussions with colleagues on the ground. Sometimes it comes down to the fact that we're dealing with complex, advanced cases. Some of the care is bespoke, it's tailored. You don't have a large volume of these patients, and so you're not saying if we treated 100, definitely this will be the outcome in 20 or 30 of them. But you listen to the patient. You hear what the patient is saying. You listen to their motivation. You listen to what the family members say, and then you go on a journey with the patient, and together you decide whether or not it's worth it. And that decision is very unique. It's a very unique decision that you make with the patient. And we do that all the time. And so you need to always be transparent. You have to put everything on the table. There is no fine print. So you talk about the real chance of death. You talk about the real chance that the outcome and whatever happens might still be dire. And then you talk about the potential possibility that, you know what, we may just be able to buy you enough time to get your affairs in order, to spend time with your family, and we could buy you a few extra months. So you have the real hard conversations. And if you're lucky, and we may be able to prolong your life even more. So all of these things are on the table, and knowing, also telling the patient that every day things could change. So that's how we make these decisions. We're transparent as a contract with the patient. And therefore, when you have an outcome like Chris's, you think about the impact you made on that patient's life, and the fact that we could buy him some time with his family where he could actually see people and not be too concerned by what he looked like. Yeah. To some degree, enjoy food, be at home. And that helps. It helps us to be able to help the next patient like him that comes along. And it contributes a lot to what we can do for other people.
Yeah, thank you. So I'm going to come to Terry and Narayan next. So you had your lady that you did the 3-valve replacement on, a little bit older, little small lady, less blood, as you mentioned. Do you want to talk about the challenges of that, but also the joy it brings, seeing someone like her then recovering and getting on with things afterwards? Terry, would you like to talk first?
Yeah, sure. Yeah, certainly for our side of things, the makeup of the patient and things like that is crucial to how difficult our job is, but also how compliant and understanding and accommodating the surgeon standing at the table is as well. They can make a huge amount of difference to our job by making simple alterations to what they're doing to help us, which then in turn will help them again. But yeah, certainly with the older people, as we've got an aging population, and the ability to perform surgery and things on older people, it certainly makes our cases more challenging from what they used to be. And obviously with the pandemic and everything, that's only going to be getting worse, I guess, because of people being on waiting lists for longer and things like that. But yeah, I mean, yeah, it's like I said, the surgeon makes a huge difference who's standing at the table. So it was a great case to do with Narayan, actually.
Narayan, you're smiling.
I think as Terry said, and as I alluded to earlier, I think the key is the teamwork and the communication and understanding what everyone else in the operating room needs to do. I think we've always got, I think, and Mimi and all the others have already talked about, we've always got the patient at the focus of what we need to do. And it's not about my operation or somebody else's operation, it's about our goal to get the best outcome for this patient. And that's where the dynamic between and the communication between Terry and I, which was clear to see in the program, about we had one goal, and while I've got to do the operation and fix the valves, Terry's got to look after the rest of the body while I'm doing that. And so that sort of interaction is crucial, because the patient needs the heart fixed, but they needs the rest of the body also still to survive. So I think it's really important. And then your question about the sort of aging population, I think Gertrude, for those who've seen the program and for those who haven't, recommend watching it. Gertrude is a wonderful sort of advert for life. She, for an 80-year-old, she's already lived an amazing life, but still has so much enthusiasm and energy for what she wanted to do for the next many years that she had ahead of us. And whether that's with her grandchildren, whether that's traveling or just seeing and doing things. And I think working with a patient like Gertrude actually gives us the fulfillment of the job that we do, because ultimately we are there to help other people. And I think almost one of the greatest joys in my job is actually a patient, when they come and see me in the outpatient clinics after an operation, is just saying thank you. It's nothing more than that. They just say thank you, and they say, thank you, you've given me my life back, you've done all these things. All, whatever it means to them is personal. But just on the other side of it, we do all the jobs. Everyone talks about what happens in the NHS and the difficulties and all the rest of it. The real joy of the job is just seeing the difference you can make to the quality of life for somebody. And I think Gertrude is a real example of that. I mean, our job, it's an honor and a privilege to be able to operate on patients, but to see that small, simple thing is fantastic. And I think COVID has actually brought home to everyone what the NHS, what all the professionals within the hospital, whether it's doctors, nurses, physios, porters, everyone is working towards that one goal. And I think, you know, the silver lining in what COVID has done is make people appreciate what the health workers do. And I mean, it's just even listening to my own two little children understanding what their father does. I think it's really important. But yeah, I think it's a key message actually for everyone, is what we do together as a team to help patients. Thank you.
I've got a few feedback comments, and I'm going to come to you, Daniel. So the first one, this one's specially for you, Narain, from Patrick van Oosterhout. Dr. Majani is my personal angel. So there's, and then Lorraine Seeger, I owe my life to Papworth Hospital team, my donor and her family, 29 wonderful years since my transplant. Thank you and blessings of the season. Sally Ingram, brilliant programme, enjoyed the trauma programme at the end of this season too. David Garrard, no question, just admiration and respect for everything you all do. Thank you. And then Sultana Ali, my mum was on ECMO for 4 months with COVID pneumonia. Although she didn't make it, I can't thank the critical care team at Papworth enough. So, Daniel, I'm going to come to you now. So a couple of sort of from the other side planning type questions. How do you choose what surgeries you're going to cover?
Well, I suppose we have a general kind of template that we are looking for. We're looking for basically complex, complicated surgeries that have multi-stages. And I suppose part of that reason, obviously, is we have half an hour per operation, so we need something that can fill that time and space. But also our audience, you know, this is a specialist factual series, and the more complicated and complex the surgery is, the more opportunity there is to delve into the specialist factual content, as we would call it, and to get as much kind of science and medicine in as possible. I suppose we have a general rule that they need to be at least 4 hours long, but I have no idea where that comes from. But but that generally is about as short as we can do. And in fact, I think one of our operations actually was that short. But I suppose it's the opportunity to really delve into the content, and also because we're storytellers, you know, if something is complicated and complex, you're going to have those, you know, those ups and downs and different textures that you kind of look for when you're telling a story. And so, yeah, I suppose that's the kind of the general things that we look for.
Yeah. So, question from the audience: were there any operations that were filmed but then not used, and if so, why?
Yeah, this year not. We usually plan on filming a couple of spares because you don't know what's going to happen. Circumstances could change, and you might film something that is no longer usable for whatever reason. But this time we ran out of time, and so we filmed just enough for the series, and fortunately that was enough.
Good. So, is there going to be another series, and what will be on it next, or what next, or have you got a different direction and take?
Well, that's not up to me. I'm not nearly that important. That's up to the BBC. I mean, it got to number 4, and you know, I know that Dragonfly would certainly be interested in making more, and it is one of the most popular specialist factual, if not just factual, series that BBC Two has, and you know, the audiences this time were terrific, and you know, also brought a lot of young people to it. So I mean, I think there's the appetite there for it, but those decisions will be made, you know, by the BBC commissioners themselves, and yeah, we just hope that
It goes ahead again.
They agree with me, I suppose.
Excellent. Okay, thank you. So, in listening to some of the conversation around this programme as I've gone around the campus, one of the things that was commented on, Mimi, is female surgeon, which is like, we're rare creatures. And what I'd like to know is, how old were you when you decided to become a medical professional? What prompted you to go into this rarefied world of surgery?
Oh God, I was very young. I was one of these. Yeah, I was very young, and I had I grew up in a house full of books, and I used to sketch out of the books. And actually, I was about 10 when I knew I definitely wanted to be a doctor. And getting into my teenage years, I actually knew I wanted to be a surgeon very early on, even before I went into medical school. And then I realized very early on, I initially wanted to do cardiothoracic surgery, and that was because of my fascination with the heart and, you know, sketching the hearts out of these books, etc. And of course, getting to medical school, when I was just blown away by it. And you know, I did start training in cardiothoracics, but you know, ended up doing head and neck, which was my backup plan actually. But I love the macroscopic element of it. So being able to look at these big structures underneath our skin, what's happening underneath the boot, the lid, just being able to instantaneously make someone better. I don't have the patience or the intelligence to be a medic. Hats off to the medics, you know. It's so much easier to be a surgeon, I can tell you that. And if you think that surgeons have resilience, you should see our medical colleagues who have to do those long ward rounds and who work in A&E, etc. And I'm always in awe of them. Or the anesthetists and their fantastic mathematical skills. I knew I couldn't do anesthesia when very early on as well, because my math was so bad. But yes, I love the fact that you can very quickly make someone better by cutting something out of them. And I know it sounds dreary, but yeah, that is it's very good to be able to do that. And it means with your hands, you can make someone's life different and better.
Yeah. Thank you. So Ian, are you the only surgeon in the room that didn't want to do cardiothoracics? And if that is the case, how come you decided to choose plastic surgery?
No. I would like to refute that. So
you did want to do cardiothoracics, is that
so
what you're saying?
I worked with a very self-attiring cardiac surgeon in Oxford called Steve Westerby. But I knew that I couldn't work to that standard, so I switched to plastic surgery.
Have you admitted that to your colleagues that you lowered your standards to get to plastics?
No, at the time, there were certain elements of plastic surgery that fitted closer with what I perceived to be my skill set.
Yes. Yeah.
And I didn't want to do a lot of work where I was doing, well, basically stenting was coming in at the time as well. So the demand for cardiac surgeons was going down. So I do enjoy this kind of vascular side and stitching small vessels together and some of the elements of it. I love the way cardiac surgeons work so closely with other professionals like perfusionists, cardiologists, the imaging stuff. So that is really interesting stuff. And what I would say about Papworth Hospital is that they vaccinated my son yesterday, and he was there for a staggering 7 minutes from arrival to vaccination. I thought I was going to get at least an hour or so.
I was about to say, is that 7 minutes too long in Papworth? No, sorry guys. But
every minute counts in Papworth.
Yes.
Some people claim they got vaccinated in 2 minutes from coming in to going out.
I have to say, I now do feel like I've missed out on something here by not seeing any cardiothoracic surgery as a junior. So I may have to come for a visit.
Can I just come in with a little comment, please, Carol? And that is that I need to give an explanation for how I found myself in cardiothoracic surgery in the subspecialty of thoracic. And there are many factors for it, but a really key moment was when my father, who's passed away, who was a consultant head and neck surgeon who did a lot of oncoplastic work. He said to me, you know what, I think you'd make a really good plastic surgeon. And I said, there's no way I'm going to do that because you told me to do that. So, there's lots of little factors that go into that.
Yeah. I had a really lovely guy who convinced me not to give up being a medical student back in the late 80s, called Professor Mike Poole, who was a plastic surgeon and the father of a friend. And that's fundamentally why I became a plastic surgeon, to please him.
So, Noreen, why did you go to cardiothoracics?
Bizarrely, actually, when I was 17, I wrote a project on heart surgery in my final year at school. But actually, I wanted to be one of those clever doctors that Mimi was talking about. I wanted to be a cardiologist. So, but I think I realized it was actually during my medical school anesthesia attachment, I realized I was drifting to looking what was going over the drapes rather than at the beeping machine and the propofol. So I think I realized at that stage my enjoyment of the heart and my joy of surgery was going to be linked in cardiac surgery. And I think with all surgeons, all of you, you eventually find a calling somewhere where you feel comfortable. I think I can tell you about the amazement of the heart, and the heart pumps blood around the body and the body can't function without the heart. But I think we all have our own reasons for finding our little specialty. And for me, it was the fascination of the physiology of how the heart worked. So not just the technical aspects of the stitching, but how it worked. But I think we're all wired in slightly different ways. But what connects us all is the passion for the job that we do. And I think Mimi nailed it on the head for me, actually. It's the ability to change somebody's life by doing an operation for all of us on the call today. And the real pleasure that gives, because you feel like you are contributing to society in your own way. And I guess it's, gratifying from that. But it's a real, it's an honor and privilege to do the job, but also it's a real joy. And I think you see that with all the surgeons on the program.
Yeah. So actually, those various comments bring me back to you, Terry. I want to know, are you good at maths? That's the first thing. So
not too bad, but technology certainly helps.
Yes. And secondly, I mean, you've got a different role, and actually it's a very unusual one. And what would you say to someone who's thinking of taking their first steps into an NHS career? How, you know, you've had that pathway that's taken you to something very specific, but how would you take those first steps?
I think definitely trying to organise some sort of experience, going into a hospital, going into certainly something within the NHS. I think it's not an easy job. It's not an easy ride. I think you've got to be kind of accepting that you're going to be working all hours, that there'll be, for example, I'm working Christmas Day this year, so you're going to miss some things with family, friends, but it's very rewarding, the results that you get at the end of it. But I think definitely sort of approaching NHS trusts, or trying to get some experience in particular areas. Yeah, I think definitely going to have a look is the best way to do it, because it'll either be for you or it won't.
Yeah. And what does working in the NHS really mean for you at the end of the day? How does it make you feel?
I think, like Narine said before, I think it's a rewarding job. It's nice when you see people leave intensive care. It's knowing that you've made all the difference that you can, and even if the outcome isn't what you would want it to be, that you've done and given everything that you can to try and get that person home to their family. I think for me, certainly, it's trying to understand and realise that all those people that are there at work to help your relative. And I think that if one of my relatives ever has to go in for any sort of major surgery, I think knowing that all of those people are there to help them, I think that's the most rewarding part of the job for me.
Yeah. So just thinking about friends and relatives, Aman, if you had a friend or a relative and they need an operation that you were the best person to do it, would you be able to do that, or would you pass that on to a colleague?
Well, personally, I'd feel entirely comfortable doing that, but we're not really encouraged to do that. So I think that I'd have to respect those guidelines. And why do I feel personally comfortable? Because I think that, as my colleagues have said before, we do get into the zone when we're operating. We get very, very focused, and the patient and the problem and the physiology and the team become the focus. But it's just not considered to be good practice. And there are many excellent surgeons around who I'm sure could do an outstanding job. So, I think, as surgeons, you've got to understand that. We all like to think, a little bit of us thinks that we're the best, but we also know there's lots of the best.
So I have to say, I watched some of the episodes, and even though I'm a surgeon, they did make me squirm a little bit. Okay. And I'm thinking of yours, Ian, in particular. So is there any job that you go, I could never do that job? Something that you look at and just go, I really wouldn't want to be that role.
Is that a question for me?
Yes, that's for you, Ian.
Okay, I'm going to answer your previous question in the style of our current Prime Minister. So on a Wednesday night when I was on call, a member of my family came in with a pretty serious injury from a firework injury to their upper limb. And I do rate myself as being, as being one of the best people that they could see under those circumstances. But at that point in time, that individual needed their father, not a reconstructive microsurgery surgeon. And the other point to make is that the idea that there's one person that is, you know, the best at something is not true. You're working as part of a team, and you're also empowering and supporting colleagues and other colleagues have empowered and supported you. So you're part of a network, and there is always somebody else. So as there was on that day, Animesh Patel is my colleague, is a fantastic surgeon who kindly came in. And the second question, is there anything that I wouldn't do?
Yes, as a career.
Within medicine?
No, just any career.
Oh, God, I don't know.
Noreen, I'm coming to you next because you're grinning away again. So
I worked in a factory making Arctic rolls one summer. I definitely wouldn't want to go back there. That was really tough. 6 a.m. till 2 p.m. shifts. My sister had done the same job the year before and told me it was all okay, but apparently she had a slightly different shift pattern. So factory work, I think, would be
no Arctic. Can you eat Arctic rolls now, though?
They are delicious. Frozen food is delicious before it gets frozen. I will put a good word in. Bird's Eye Wolves is the company I work for, and their stuff is fantastic. No additives or preservatives are put in, and then it gets frozen.
Excellent.
Blueberries. Frozen blueberries are better than the ones you buy in the shops.
So that's our tip for the day. Okay. So, Noreen, is there any job that you would particularly like to avoid doing?
I was laughing because it was a cruel question, but now that you come to me, I'll give you a link to Ian's last story, Arctic Explorer, because I can't stand the cold. So I think anything to do with being up in Antarctica or the Arctic or whatever, because my 6-year-old son is learning about the Arctic and Antarctica at the moment. So being an Arctic explorer is something I definitely couldn't do. I think watching the program, as has been alluded to, we're all in awe actually with what our colleagues do, and it's very impressive. I think instinctively, I'm not 100% sure I could do any of the other jobs, and possibly even in medicine actually. But it's, yeah, I think it's getting an understanding of what we all do together to make the healthcare system a better place. And I mean, I'm constantly in awe actually of my nursing colleagues, and especially with what they've done in COVID. I'm not 100% sure I'm cut out to do their job, but it is really inspirational to watch what they do. So, but yeah, if you really want an answer, Arctic Explorer.
So, strange enough, you partially answered my next question there. So you'll get a reprieve now, which was, have you watched the series yourself, and what do you think of them? So I think I'm going to come to you, Mimi, for that one. Have you seen any of the other episodes, or do you find it difficult to watch yourself on TV?
No, I've watched them. And I am in awe of all my other colleagues, including the trauma guys, who are just impressive. And yeah, I watched it. When I watched mine, I thought, oh my God, I'm so loud. And and actually, Daniel and his team would have known that, because we got to see bits of it before to say, is everything okay? And I kept on saying, don't you think I sound loud? Can you? And actually, there are bits, as a woman as well, there are bits of that, of the experience that make you feel, listen, I don't want to come across too hard. And these are the little things that, as a female surgeon, come through to you, that you want people to see you as being part of the team, but not overbearing. And I hope that, and that was very important for me to see that came across. And these are the little differences between how perhaps women see themselves in leadership roles and men see themselves. So that was something I had to get used to. And I think the most useful thing that actually one of the chaps from Daniel's team said to me is, this is your personality, and we can't edit your personality, and just go with it. And so I've been able to, and I've been able to appreciate that, especially in the context of the wider team I work with, whom I care for so much. I think we all complement each other. There's a lot you can't hear in the background because it's silent, they turned off the volume, but a lot of we work so well because we've gotten to know each other And, it makes for such a wonderful working environment, being able to finish each other's sentences or being able to enjoy jokes, etc., and make a much lighter work environment, despite the fact that we're doing something really complicated.
Sorry, can I just mention something? Having worked with Imi, you in your episode, you were loud and confident, but you're much louder when you come and work with me at Papworth.
Brilliant.
It was a joy to collaborate with the Papworth team and with Amma and his team. It's such a joy. We're so lucky to be next door to each other, and we've been able to do some really good quality work. And that's such an exciting part of the work we do, that collaboration. And it's great. We're very lucky.
Yeah, that's great. That is great.
So
yeah, don't change, Jimmy.
Good. Thank you.
Absolutely. Yeah, I think that it's quite an interesting one, because there's a lot of work going on at the Royal Colleges at the moment around, being what you can see. So having an example in front of us of the different I look at the 5 surgeons in this room and we're all different, which is fantastic. It's just brilliant that we all come from different backgrounds, walks of life, and and that's will help encourage when people can see that and see the different roles, like Terry's role as well. It will encourage people to come into the NHS and into the specialties. So, Aman, what did you think of the other? Have you watched this series?
Yeah, I have. I've absolutely loved the other episodes. In fact, more than I enjoyed mine, although mine was fantastic. It's great to see what other people do. It's great to see how they work, and it's great to step into someone else's operating world. As surgeons, you always learn tricks from other surgeons. So, some of Ian's techniques and Imi's techniques, are little things, I might use next time. So it was great. And I think one thing that I'd like to also get across is that surgery is really fun. Working in the NHS in a team is really fun. Making things better is hugely satisfying as well, but it's an enjoyable job.
Yeah. Okay. Talking about the surgery, so it's a question that's come up on the chat. A couple of the patients were left still opened up, and then the surgeon returned to them later or the next day. How do you stop things deteriorating? So how is it that you can move away from the patient and come back? I think Mimi, you stepped away, didn't you, for a bit from one of yours and then came back. So
yes, often when it's quite normal and it's encouraged that if you're doing a very long case, you take a pause, and that's why you have a team. You've got the anesthetist who's really the person keeping the patient alive. They really hold things together while you do the work, and you don't have to think about anything else but the incisions you're making, etc. But you are encouraged to take breaks, because if you don't take breaks, you get tired, you get ratty, you lose your concentration. It's not a very nice place to be. I've operated hungry before, and it's not nice, and you don't want to do that. And I think everyone here recognizes that. So that kudos goes to our anesthetic colleagues who know just the right amount of anesthesia to give, the painkillers, the fluids. So the patient is still living and breathing, and they're still alive. And so it's okay to do that. You just don't do it for prolonged periods of time. And that's why planning is very important. Of course, the other thing is when you're working within a multidisciplinary team. So for example, I work a lot with plastic surgeons, Nick Segarin and Ahmed Durrani. And so we try to dovetail the work we do, and sometimes we are actually overlapping. And therefore, when I've stepped away to do something, they're doing something else. So we try to fill that time up as constructively as we can. You often just don't have a patient, in my theater anyway, with what I do, not having some kind of benefit from the downtime. So that's how it works. I don't do the other much bigger procedures like the one that our fantastic colleagues did with the visceral the visceral operation, the big abdominal operation. I mean, that was fantastic. That's 2 days work. But again, our critical care teams play a huge role in making that patient comfortable and well enough to come back the second day for that work. So that's amazing.
Yes. So, and as Daniel commented, these were all longer operations. So if you think, if you were driving on the motorway for 4 hours, you would always take a break, wouldn't you? Because otherwise you'd lose focus and concentration. So it's exactly the same as that. So Narain, bit competition time. Who's done the longer operation, you or Aman?
It's never a competition. If you're asking about my longest operation, I still remember even the exact date it was on. I won't share the date just because you can work back from it, but it was about a year after I'd become a consultant, and it's an operation of a patient that had had a previous operation done by one of my colleagues. All the clockwork had got infected, and you spend many hours deconstructing it, taking out all the infected work, and then reconstructing the heart, the aorta, the blood vessels, and 22 hours later, so I didn't quite reach the complete day, but 22 hours later, we finished the operation. And just to pick up the comments my colleagues have already said, that was not just one person, that was many people contributing to that, coming in and out and making sure that you got the right outcome. But I will never forget that day. It's definitely etched. I've not come close to 22 hours since then. So, but it's simply because a patient needed operating there and then, and we needed to do what we did. And it's again, just gratifying to have got that patient through that. So yeah,
brilliant.
So it's not a competition, but I'm sure Aman will pass comment.
Yes, I think my longest has got to be about 16 hours, which was in head and neck oncology like Mimi, but from a slightly different specialty. So that's sort of an 8, 9 o'clock start and midnight finish. So Aman.
Yeah, so...
are you going to win this one then? I'm inducing competition in Papworth.
No, we're not like that.
We're all friends.
Where is he? Let me show. Sorry, I couldn't find him. Well, you know, the truth of it is that you work to your individual stamina.
Yeah.
And then you have to decide, is it safe to go on? Is it in the patient's best interest? Do you stop for a moment? And that's why operations are staged. As a much younger surgeon, the longest stretch that I've been involved with, sort of non-stop, no, it wasn't actually non-stop because I did actually have little sleep breaks, was when I was involved with 3 back-to-back double lung transplants. And I was a fellow in Toronto, and it was an amazing experience. The fellow went out and got the organs, and then you took them back to base, which was Toronto General Hospital, and you would then be involved in the implantation. So the fellow would probably put in one side, and then the fellow who was still at home would put in the other. And that became 3 back-to-backs. So it went on for about 72 hours. And I had, the times I slept were going to and from the retrievals. So I probably slept for about 8 to 10 hours in that period. And at the end of that, I was sent home because I was so tired. I didn't know it. But the patients did well. So, you know, we do staged operations, and it's not a, you know, it's only a competition if you're crazy.
Yeah. Question for Ian. Someone's put this in the chat. As a non-medical scientist, I was surprised that the surgeons had to search for certain body elements and that all bodies different in layout. How much is this an issue for surgeons?
Is the question that bodies are different in layout?
Yeah, well, like when you were looking at the arm and you have to look for things, don't you? And it's not always all in the same place. So how much of this is an issue?
Okay. I mean, yes, it's true that there are some anatomical anomalies. For example, if you're talking about the median and ulnar nerve, there are anomalous connections either upstream in the forearm or downstream. One is called the Berrettini, one is called the Riche-Canoe connection. But in those circumstances, we were dealing with a limb that had been dragged down partition on the motorway, and stuff had been pulled and wrenched and torn. So what we were trying to do was, we knew we'd lost a huge amount of soft tissue, and we knew that we wanted to create a limb that was functional. So we're trying to find out whether there are nerves that will potentially drive muscle, should we have to transplant muscle into the limb, and there are arteries and veins that will be able to support a free flap, because we're almost certainly, if that limb was salvageable, going to have to put a free flap on it to, which is tissue transplanted from elsewhere in the body to support it. So my role, I think, was to be the judge on what was alive, whether to give a clear and dispassionate view on whether reconstruction would be appropriate, and to find the necessary bits to do it. There could have been the potential to move on straight to a free flap at the time, if there was a critical structure that couldn't be covered for a day or two while we prepared for it. But it's not that, you know, bodies are generally pretty much put together the same. Another point to make, which I think was made earlier on, is that we are also custodians of a huge amount of physical and technical resources. The amount of money that it costs to take these patients to theatres is huge, and I'm mindful that this is, you know, taxpayers' money, and that people are struggling. So I do think, and I think we all do, think we contextualise what we're doing. Are we using the resources appropriately? And one of the things that we don't want to do is put the patient through a futile procedure, something that's not going to work, a full storm, and we don't want to spend a lot of taxpayers' money and time. So part of my role was to say, you know, this is where we should go, and I think this is it. You know, this is where we are.
Thank you for that. Yeah, that's really helpful. So I think we've got time for one last question. I'm going to direct this one to Daniel, actually. Is there anything that the production team wished they could have shown that wasn't filmed?
Yes, most definitely. We desperately wanted to film the DCD heart transplant at Royal Papworth. And obviously, because transplant work is central to what they do. And last time we were fortunate enough to have a double lung transplant. And it wasn't through lack of trying, and also from huge amounts of support from Papworth and the transplant team. We went on kind of what went on call, where basically, you know, the production team basically was needed to be made available across a period. Yes, you weren't allowed to, you know, go on holiday or drink too much. So we could respond if one of our consenting patients ended up getting an offer of a DCD heart. And then we went on kind of soft call, which meant that, you know, everyone was willing to be called at any time of day or night. And if we were able to assemble everyone, we would do it. And we managed to do it, well, respond twice with consenting patients. And we got there in time to send our team out with the retrieval team to capture the arrival of the patient at hospital. And unfortunately, well, very much unfortunately for the patient, but also for us, because it was something we wanted to feature so badly, the transplant didn't go ahead for one reason or another. And so we, yes, we were left with that being unfulfilled, unfortunately, and, you know, disappointing for all of us, but as I say, especially for the patients who were waiting on it.
Thank you. So looking at the clock, 7:30, I think we've filled our hour quite well. So thank you very much from all of you. I haven't managed to say all the comments, so apologies to those watching. There are many wonderful comments around support and thanking you all for your hard work, that you've been brilliant. So thank you again, and I think that's the end of the session now. So
thank you very much.
Thank you to everyone, and Merry Christmas.
Thank you.
Merry Christmas.
And a Happy New Year.
Yes, let's hope so.
Take care.
yes.